Good evening, everyone, and thank you for joining us for tonight's COVID-19 update webinar. My name's Beth, and I am joined tonight by our panel, Associate Professor Charlotte Hespy, Associate Professor Penny Burns, Dr. Kerry Chan, and Dr. Kathy Dempsey. Before I get started, I would just like to make an acknowledgement of country. We recognise the traditional custodians of the land and sea on which we live and work, and we pay our respects to elders past and present. I'm going to pass you over to Kerry to give us a bit of an update. Thanks, Kerry.
Thanks very much. Before I start, can I also acknowledge the traditional custodians of the land on which we're meeting and pay my respects to elders past and present. So the case numbers in New South Wales have been high, but we have been seeing a flattening of the curve. It's too early to actually predict whether that is going to be sustained. And we're hopeful still that we will see a decline. What we are seeing is that the case numbers in some of the local government areas of concern are showing a stabilisation and decline, but we're then seeing an increase in areas that are such as the Central Coast, Illawarra, Wollongong area, and also the inner city areas, so inner west, Marrickville, Waterloo, and into the southeastern Sydney suburbs. Now, obviously, this is of concern as we see the growth outside the local government areas of concern, and the disease is largely tracking through vulnerable groups. So we're seeing quite a significant impact on those people with Aboriginal people. We're seeing social housing impacted, people with drug and alcohol issues, mental health. So we're seeing it pick up very marginalised communities as well as its impact on the cold communities of southwestern and western Sydney. On a pleasing note, and can I thank you very much for all your efforts. Every day of the week, Monday to Friday, GPs are churning out over 70 to 80,000 doses of vaccine. And that is so critical to us, reducing the morbidity and mortality impacts of COVID-19. We're currently at 78.8% of the population have received the first dose, and we've got 46.5% have received the second dose. To live with COVID, we're going to need as high as possible vaccination coverage as possible. The 12 to 15-year-olds are eligible from today, and it will be good to see if we can get a very high vaccine coverage in that age group, as well as we still have vulnerable people over 50, over 70 that are yet to be vaccinated, and we need to get those second doses in individuals. Over the coming 2 weeks, the supply for the state in terms of Pfizer supply or vaccine supply in general is limited, but I know that the Commonwealth is pushing out both AstraZeneca and Moderna through pharmacies, and obviously AstraZeneca and Pfizer vaccine through general practice. And it will be critical. We will be relying very much over the next couple of weeks on the GPs and pharmacists to really increase that vaccine throughput and really give every jab you've got to your patients. And before we see, the state will also have an increased supply coming into October. So I just wanted to again express my intense gratitude to the work that GPs have been putting in, and I know that I'm asking you to do even more over the next couple of weeks, because it will be so critical that we get as many vaccines in arms as quickly as possible to get to a way of living with COVID that has the minimum impact on the community. And as I said, at the moment, it is really critically impacting on the most vulnerable in our community. Thanks, Charlotte. I'll leave it there.
Thanks, Kerry. What I might do before I start moving to questions is hand over to Kathy too, to maybe give a little update about the work you're doing and some of the areas that particularly impinge on GP work.
Yep.
Thanks, Charlotte. So from an infection prevention and control perspective, a lot of things have remained constant over the Delta wave, and what we've found that we've had to do is really hone in on helping clinicians understand the implementation of the guidelines. There's always been, particularly when we're in the middle of an outbreak, a lot of concern from clinicians, and I guess often an approach to, more is best, when in actual fact we find that applying or application of PPE based on risk is really most important. We're doing a lot of work currently around recognising healthcare worker acquisitions. So when we're interrogating that data, we're also interrogating some of the adverse events that have been reporting, and hopefully some of that information will start to filter out to the system. So, for example, we've recently just been able to determine that out of over 1,161 staff that have been furloughed that have been healthcare workers, 9 of those have actually acquired COVID, and they've been related to direct breaches. Some of the key areas of concern continue to be our breakout areas, so tea rooms, places where we remove PPE, anywhere that we congregate as a group, then that seems to be our areas of potential transmission events. We've been working closely providing infection control support to Far West, so Wilkenya, Dubbo. We've also been helping with some of the regional areas with setting up community support hotels and special health accommodation and sort of hybrid approaches with that, working closely with some of the prison populations, trying to really get those areas to understand how to apply infection prevention and control. The guidelines are fairly consistent. Again, we've just been trying to help sort of highlight, prioritisation of P2N95s, and probably the biggest thing is working with public health to align some of the risk assessment based on wearing of PPE, which is a little bit different to how we might have normally overlaid those things. Thanks, Charlotte.
Thanks, Kathy. I might just put a little bit of personal insight there. Certainly as a GP working in an area where we're starting to see quite a number of COVID infections, we have really learnt the joys of your particular little risk assessment and what we're doing in terms of wearing PPE. And can I recommend everybody, if you don't have it, then I'll get Beth to share the link with in terms of where the risk assessment for PPE wearing is, so you can look at it, because it does save you having to have staff off as being close contacts when they might be casual or in fact not a contact, deemed a contact at all. And that's really, really helpful in terms of keeping your clinic open and running, as well as, just a good habits to get into. Penny, you wanted to say something?
Well, actually, I might lead into you, Charlotte. Can I ask you a question? So I know that recently you had some positive cases wander through your vaccine clinic, and you didn't have to actually close down or lose staff. Are you able to quickly run us through why and how you managed that?
Well, we were very lucky, actually, every time it was a weekend that we got it notified. So we're able to do the cleaning very efficiently on a Sunday, so having the clean through. But because our whole way of running our vaccine clinic is completely separate to the main clinic, it's on a different floor, the check-in is outside, the person who's checking in is wearing full PPE, each of the social isolation between patients when they come in, the flow through is so quick, there's no association between patients by and large. And it's only the nurse who's doing the vaccinating, and they're in full PPE, and then the patient's outside for the waiting zone. So it does make it far less complicated. But what it did actually make sure we reinforced with everybody was the importance of staying in your own zone and not going between them, and how if you do actually happen to go up onto the vaccination clinic level during a time, then you did actually have to go and get tested for as a casual contact. So we certainly had people affected by as being casual contacts, but no one, only one was close, and that was a nurse who did have to spend considerable time with a patient who had a reaction afterwards. So it was about the time. But what's really, I think, important at that is about the importance of making sure everybody's with you, that they are doing the right thing, but even more so that we're doing telehealth, because we would not be in the situation where we are being able to maintain normal staff and normal services if we hadn't converted over to the vast majority of our services being done by video, because there's just too much now. I mean, all of these cases were, no symptoms, no known contact at the time they came through the vaccination clinic. So you just can't know, even if you put all the right questions in place, that someone that you're seeing face to face is not actually potentially a COVID case, which could shut the entire floor down if we were running in any way differently from what we're doing.
And I guess maybe that if Kathy, if you would be able to just talk to us very quickly about fit testing and fit checking. I know that there's a lot of angst amongst some GPs in terms of not being able to get fit tested, but I think some of the intention from those guidelines was not that necessarily had to be the case.
Yeah, thanks, Penny. Well, according to the Australian New Zealand's, respiratory protection programs are required, and part of that is fit testing. Now, having been in this role for over 25 years, and 15 years ago we looked at fit testing, and for a number of reasons, we didn't specifically go down the route of fit testing. Now, good or bad, we are in this realm of being, implementing fit testing. But, what I stress to people is if I am fit tested today against a certain respirator, that does not guarantee me a fit seal tomorrow if I do not administer a fit check seal. And so for those areas that are not fit tested, we have relied on fit checking for over 30 years in health and have done very successfully. I think, again, whilst, New South Wales Health has fit tested over 50,000 healthcare workers, and it is part of our matrix of making sure that we've got people in the right PPE. Fit checking cannot be underestimated. We can't think that fit testing is the silver bullet. It is one of a number of strategies to look at making sure that we've got, a sealed respirator. So I know that many GPs will not be able to fit test, and in that, vein, then it's important that you've done your donning and doffing training, you've looked at videos, you're fully across the PPE that you've got, it's TGA, registered, it's a P2/N95, you're able to get a fit check seal in those environments. And look, what we're seeing definitely is when you've got complete source control, so the source has got a surgical mask on, we're seeing no transmission in the healthcare environment, when you've got a surgical mask as source. And then also we're seeing really good protection with surgical masks plus protective eyewear such as face shields and P2N95s for those high-risk areas, with addition of eye protection as well.
Can I also note that if you're wearing a gown, that also does mean the PHU takes you far less, like they take you more seriously. So just to reiterate, it's the right mask being fit checked, even if you can't be properly fitted, with the goggles or the shield and the gown when you're seeing clinical patients in general practice, which it's a pain. But it's nowhere near the amount of pain as having to close the place down.
And it doesn't matter what sort of eye protection, but it is really, really important that the eye protection's there, I think.
Yeah. Just if I can explain, pre-COVID, when we looked at public health responses and contact tracing, things that occurred outside of a hospital environment, public health took the lead in and did very well. Usually what used to happen inside hospitals is that infection control and infectious diseases would normally take the lead in outbreak management. And so we are very used to overlaying things like PPE and layers of PPE and how those layers remove people as contacts. So we've worked very closely with public health, hence the latest edition of the risk matrix. I think there's still a little bit more work to go on that. At the last point, we didn't include vaccination status. However, CDNA and AHPPC are working on a version that does include vaccination status, and New South Wales is currently also working on that vaccination status. As we get additional information with our healthcare worker acquisitions, I think you'll start to see some of the matrix sort of move more to sort of the left. So when you've got any layer of PPE, there will be a layer of protection. So some of the things we've also tried to teach public health is around breaches of the neck up for COVID are the highest risk. So therefore, depending on what interaction has taken place, there should be less concentration, for example, on the use of gowns and gloves, rather sort of hand hygiene and then your neck up. Thanks.
So Kathy, there's a few questions coming through here. One about how long you can wear an N95 or a surgical mask, one about additional protection of gloves, and one about the recommendation for any consult worldwide, statewide as well.
Yeah, so the length of time for a P2N95 is up to 8 hours. Now that's almost impossible. Nobody's going to sit in a P2N95 for 8 hours. So you have to take into consideration, breaks, drinks, things like that, and really just well-being. So anytime you remove a P2N95, it should be discarded and then a new one put on if you're using a disposable one. With a surgical mask, they are normally efficient up to about 4 hours. But again, anytime you remove it, you should replace it with a new one. And sorry, what were the other questions, Penny?
Oh, I guess the other one was around risk. So at the moment, there's someone who's written, they're a GP in Wollongong currently wearing eye protect. Should they be wearing currently eye protection gown, N95 and gloves for all patient contacts, or only patients who are more high risk? This is Illawarra, Wollongong area.
Yeah, so look, if you're in a high risk environment, I mean, that's part of your risk assessment. So if you know that there's a large community transmission, occurring, then it's around trying to screen those patients and segregate those patients as they come in. So that's around zoning and separation. And if all of that leads to you that they're a high risk, then depending on the contact, if there's limited contact, so it's a consult, then your PPE would be at minimum. So source control for the patient, so that's a surgical mask as a must. If they can keep that on for the entire interaction, then that's great. Then obviously, if we're suspecting COVID, then that's a P2N95 and eyewear. If it's lower risk, then that would be a surgical mask and a protective eyewear, so a face shield or eyewear, glasses in that sort of environment. If then there's a lot of hands-on, then it would be gloves, and then if it's close contact, then gown on top of that.
And Kathy, another question around the HEPA filters, ventilation, and any specific guidelines coming out about that and what's happening there?
The problem with the HEPA filters, so what we're talking about are the mobile air scrubbers, which most of them operate on a HEPA filtration system. Some have some internal UVC or UV components. There are some that also operate on nanotechnology. Their use in health is not as substantiated in some other environments. My advice would be to look at your ventilation system as a priority. Any enhancements that you can do centrally on those is far better then implementing mobile units. So it's around getting those systems properly sort of maintained. Can you enhance the ventilation? Can you add HEPA filters at any point in your centralised service? Because the problem with the HEPA filters, if you do decide to go down that track, in confined areas, the issue is how many do you need? Does that change the airflow? And we're not really sure about that at this point. We're reluctant to put them in healthcare environments because of the risk of them then drawing all of the air into that spot. So it's around placement. Usually placement is best closest to the source of generation, and that's your positive. So they're the difficulties. We're looking at some of those systems, if you like, at a state. We've got a statewide ventilation system. The best document at this point that may give you some advice is the World Health Organization Roadmap to Ventilation, and I can provide that to Bethany later. The jury's still out. We're trying to work out where the best placement and use. Some of our hospitals are using them in sort of high-risk areas where the ventilation's poor and the risk is high.
Fantastic. Thanks, Kathy. And look, just a couple more questions. One is, do prescription glasses count as eyewear? And I know the answer to that's no. How are open doors and windows viewed? And then another question is, if I take off my face shield between consults to do some phone consults, how do I manage that?
Yeah, so in terms of open windows and fresh air, we definitely in New South Wales, the engineers and our ventilation experts in health infrastructure are very supportive of open windows because of the ventilation that it creates, and therefore the greater chance of diluting viruses. So we're very much in favour of open windows. Melbourne may have a slightly different approach to that, because I know they actually nail shut all their windows and balconies in their quarantine system, whereas we leave all ours open, and we've been able to manage that successfully. So I personally think, and so do our engineers, that ventilation, open windows creates good dilution of air. In terms of shields, if it's personally allocated to myself, then I can just clean that with a detergent disinfectant wipe, hang it up to make sure that it's stored away properly, and then I can use it during the day for that. Was that all of them?
Yeah, no, that was great. Thanks.
Yeah, thanks.
So I'm giving you a list. Look, there's one here too that last one, and I'll give you a break. It's from a GP in Coffs Harbour saying, look, we would have to shut down if we had to wear full PPE. Could you take them through how that would work in their practice?
Can I also add that they're saying that they're not doing PPE for their vaccination clinic, and certainly for vaccination clinics, we're recommending full PPE. So maybe you can talk about why they should be, Kathy. I think I'm going to add in here, we would have had to be shut down 5 times now. We would not have been able to run as a vaccination clinic. It's definitely worth it financially to kit out in full PPE. They don't have to, it's not as big a deal as you might think it is.
Yeah, so look, I mean, most ICPs would cringe at the term full PPE, but we know that it's out there. And look, the vaccination hubs here, when you look at it, you've got people that should be presenting well, so they go through the screening process of, I shouldn't be symptomatic, I shouldn't be turning up if I'm a contact, I shouldn't be turning up if I'm positive. You've got source control, so making sure that all those that turn up definitely have a surgical mask. Now, if they turn up in a cloth mask, then rather than getting them to remove it, you give them a surgical mask to put over the top, right? So that you've got source control. The majority of our vaccination hubs in Greater Sydney are all in surgical masks with a face shield. So a face shield will provide an additional 20 to 30% coverage and protection. The research is telling us we are getting at least 67 to 70% protection from a surgical mask. I'm happy to go to bat and argue with public health that if you've got a positive and they were wearing a mask the entire time and your staff have been at least in a surgical mask with a face shield, there's no requirement under the vaccination process for gloves, so long as hand hygiene's been implemented, and the same with gowns.
Yeah, and Kathy, that's what we're seeing when I've been working at the mass vaccination hubs. We're just in a surgical mask, the face shield, and then we're not spending a lot of time with any one patient. So I think there are ways around this, and I think it's very much a risk assessment.
And the face shield.
Can I just raise something there? I think Kathy, just to think about it, it also depends on how you're positioning the patients to wait for the 15 minutes. And I think Charlotte wisely chose a well-ventilated space. I think you said outdoors. So I do think that there are some issues there, things that we need to learn about. And also the Kudos Bank Arena and some of our vaccination clinics are very well-ventilated spaces. So just put that there. Kathy, did you want to comment on that as a factor in the risk assessment?
Yeah, no, definitely. Thanks for that, Carrie. Ventilation and good ventilation, air exchange is important to make sure that you don't have those sort of pockets of stagnant air that would increase, your risk.
Fantastic.
Can I just, I think it's, as GPs, we all know that it's a big cost running these vaccination clinics. But again, remember, it's a big cost if you actually have to not have staff be able to work and have patients at risk. So it's about risk mitigation and appropriate management. And as GPs, we do need to lead the correct way in which to do this. And it's difficult. And the PHN should be assisting with supplying you with PPE as well. And so if they're not, then go and ask them for it, is what I would say.
Yeah, it's also a good use of extended and sessional use PPE so that you can, keep your PPE on for an extended period of time, so not change it in between. Obviously, wash your hands in between, but the PPE can stay consistently on until like either a break or whatever, you move to the next zone. Things like that. The only other time we would also enhance PPE is if you're doing targeted groups. So you know for a fact that you've got, a group of close contacts that you want to move through your centre and vaccinate, then you would need to risk assess slightly higher than your other population.
I just noticed someone saying that their PHN is not supplying with the PPE, and so I would just say go back and ask them for it, because that's certainly part of the deal with the federal government. The PHN should be supplying you with PPE. A question about how often to change gowns, Kathy?
Yeah, again, it really depends on how you're using them. So we're less inclined to have extended sessional use with gowns because usually we wear them for close contact and close interaction. And, we obviously don't just have COVID, we have other healthcare acquired infections. They can be done in terms of extended use, but there's no time frame in those. So depending on how and why you're using them, again, I could stay in them until I next have a break. And, that would normally be a couple of hours unless I've had direct contact and direct exposure to blood and body substances. And, I've been contaminated with those on my gown.
Kathy, there's another question here I think is important. What about patients with mask exemptions? Should we refuse to see them face to face? I mean, that's a little bit.
Yeah, look, I guess the thing is when you don't have source control, if they've got an exemption for mask, I would be asking whether or not they would be prepared to maybe put a shield on for the duration of the interaction. Otherwise, your risk assessment may need to go to that next level. So you don't have source control. You really want to make sure that you're in a really well ventilated area. If it's a close interaction, then your assessment may automatically need to go to a P2 N95 with the addition of a face shield.
And then there's a couple of questions here around getting a COVID test before getting patients to get COVID tested before coming in, or wearing face shields coming in for vaccination. But I think if they're...
And also rapid testing. So maybe Kerry can talk about all of those issues.
That'd be great, Kerry.
Oops, she's just disappeared.
We'll give Kathy a break.
Oh.
No?
Yep.
All right. Before, so can I just ask Kathy, well, till Kerry comes back, Wally's just asked, what exactly is a deep clean? Is it really necessary?
Yeah, so a deep clean, you know, for us, it's more than, you know, a touch clean. There's many different definitions of what a deep clean is. You know, people call it a pathogen clean. They might call it a terminal clean. So often for clinic type environments, what we do is high touch point cleans. So just those high touch points. You don't need to do a deep clean in between every single patient. So again, depending on what's occurred during your clinic, if it's, for example, a clinic that does a lot of wounds and, you know, a lot of sputums and things like that, that might be different. Whereas if it's just a clinic sort of consult, high touch cleaning in between, and then you can do sessional deep cleaning, which will either be, you know, at the end of the day or at the end of a session.
And so, Kathy, I think the question is, what exactly is that when you do a deep clean?
Oh, it just means
and
it's a deep clean. It means you, you clean everything.
Okay.
But specifically, I suppose, when the clinics are asked to do a deep clean after a COVID patient's been through, it'd be quite nice to say, how different is that from what we would normally do?
It's just more than what you would normally do. So, you know, if normally you kind of do a few high touch point areas, it's really about cleaning anything that is possibly cleanable. You know, certainly, because I know a lot of clinics may have carpet. So, you know, again, depending on what's happened, it wouldn't necessarily be a shampoo, but if it's been 3 months since you've done a shampoo, then that's your time that you might want to do. It's really, you know, more than what you've done. It's a thorough clean, and it's particularly a thorough clean of anywhere that patient may have had contact with. So desks, seats, chairs, leaning over counters, seats in the clinic area, anything to do with either sphygmos or any items that have been in contact, you know, those things that you wouldn't normally clean in between each and every patient is where a deep clean, you now need to clean sort of all those things.
So effectively, if there's nothing special, no special chemicals, no special process, just a really thorough clean.
So it's a manual clean and disinfection.
Thank you, Kathy. I think that's really helpful. So Penny, do you want to leave off for Kerry?
Yeah, so, actually just one last question. Sorry, Kathy, just before you go. So talking about gowns, so there's been a bit of discussion here about gowns, like what gown should they be wearing? What type of gown, I guess, and how many times a day when should they have to change it?
Well, a gown really just depends on what it is that you're undertaking. So if it's purely for COVID, then anything that is either an isolation gown will provide you with protection. It needs to have at least a fluid resistance level 1, 2, or 3, which will penetrate certain levels of fluid. And again, you know, normally we would change gowns in between each and every patient. You know, when we've applied them, for example, in sort of clinics, because we're doing sort of COVID testing, or you know, we're running sort of groups of things, you can do it based on a task. So say, for example, I'm going to run temperatures of 4 people that are in an environment. Essentially, I can keep all of my PPE on. I make sure that I wash my hands or change my gloves in between each and every person. But unless some exposure event has occurred, I could keep my gown on for those 4 patients. Right.
So, Kathy, if I'm seeing patients and we've screened at the door and I'm wearing a gown and gloves and surgical mask and a face shield, so they're not coming in with respiratory symptoms, I don't suspect anything. Between those patients, I could leave my gloves on, my gown on for most of the session. without having to change it, and just change gloves between patients if I'm touching patients. And
if I'm screening at the front, all right, depends. If there's no contact, then essentially there's no contact and I don't need to change my gloves, right? So you could essentially stay in that PPE for the entire day if I'm not going to eat, drink, or go to the toilet, right? But obviously, because we need to have a break, then when I have a break is when I would change. Or if I'm going to another zone, right, then I need to separate what I've been doing in that zone. I would completely doff, remove everything, wash my hands, and then I could move to the next zone, and then I would apply the PPE required for that zone.
Fantastic. Thank you. We'll give you a break now.
All right, so over to Kerry. Do you want to lead that off to Penny as you're on a roll?
So Kerry, there's been lots of questions coming here around vaccinations and I guess sort of about I guess things like doses of vaccination and
that's for 12-year-olds, a small 12-year-old. Someone's asked whether they need to have a lesser dose, and there's also clarification about the gaps being recommended for Pfizer and Astra.
Okay, so in terms of the dose is just as recommended by ATAGI, so no difference if it's a small 12-year-old from a small, it is the recommended dose. The interval's an interesting concept. So we're going back now to, because vaccine supply for general practice has improved, and we are just recommending going back to the original Pfizer recommendations, which is about 3 to 6 weeks in terms of the vaccine. And it is important to get vaccine in arms, first dose, and then second dose. In terms of the AstraZeneca, we asked GPs to bring forward the second dose. Clearly the interval's somewhere between 4 weeks to 12 weeks. We've asked you to bring forward the dose, knowing that in the presence of their likelihood in Greater Sydney in particular, that they're going to come in contact with COVID. And so we know that even after the second dose, it's going to take a bit of time to get protection. And then we know into the future there will be booster doses. ATAGI's yet to provide advice about booster doses, but there will be boosting in the future. So really this is about a risk discussion with your balancing the duration of immunity, the level of immunity, but understanding that the COVID risk in Sydney particularly is real, as it is in many regional areas, and therefore we would like to get that second dose in as soon as possible.
And Kerry, there's been a question asked about from a GP in Canberra and working in Queanbeyan, and just again asking about the duration between the 2 AstraZeneca doses and what the preference is there.
So we'd recommended moving it down to as a minimum of 4 weeks, but as I said, we're recommending that 4 to 6 week interval, again on that basis of getting the second dose in as quickly as possible, noting that we are going to have to boost probably in the longer term, but it's really about trying to get that second dose in. So we would ask that GPs actually actively look at those people that have had AstraZeneca doses and really try and get them in for their second dose. And we would also like to get in more of those first doses as well. There's still a number of people who are in higher risk groups that are not vaccinated. And we really just want to make sure that you go through your patient cohorts and just really redouble your efforts for those people that really require that cajoling to come in, because we don't want anyone left behind. And we want to make sure we're picking up all of the disadvantaged and vulnerable groups.
And Kerry, I know there's a push on to get Aboriginal and Torres Strait Islanders vaccinated as well because of lower numbers. Did you want to comment on that?
That's right. So look, it's been really pleasing, the work that's been going underway, and I just want to acknowledge that GPs are doing a great job in that regard as well. But there certainly has been a concerted effort working in partnership with our AMSs. I know there's some examples where the AMSs have been working collaboratively with GPs that might have had access in a particular area to Pfizer to vaccinate Aboriginal people. So really this is a partnership. We recognise the vulnerability in terms of the fact that Aboriginal people have higher other comorbidities, But we also recognise that we have to work very hard and in partnership with Aboriginal AMSs and to get those vaccination levels very, very high. We also understand the difficulties with rural remote communities, and we've been doing work with sending teams out to those discrete communities to get them vaccinated. So this is a sense of urgency. And again, I just want to acknowledge that GPs see a large number of their patients are actually Aboriginal. And just again, please work with them to get them vaccinated. And we have noticed hesitancy across all people from all different walks of life. And I just think GPs are just so well positioned to talk with their patients through the facts. And so again, just really want to support your efforts in working with patients to advise them about the risks of not being vaccinated.
Thanks, Kerry. And can I use that as a segue into that everybody needs one dose to be able to have a second dose. So please get that first dose in as soon as you can for as many people as possible with whatever vaccine you've got for an appropriate age group. 60s and over, it is still AstraZeneca as the recommended vaccine. That you do need to give a second dose to actually get them the coverage that we really need in order to keep the community safer. But it does, even having two vaccines does mean that some people will still get an infection with COVID and therefore potentially transmit it to others and still potentially be sick. But it does protect people significantly with that second dose from being hospitalised and or ending up dying as a result of COVID. And that's the ultimate goal of the vaccination program. So you can still get an infection, but having two doesn't stop it 100%, unfortunately, but it does, it looks like almost 100% protecting you from death. And just quickly segue into Moderna. General practice will not be getting Moderna this year. They probably will get Moderna next year. That's a decision from the Department of Health. It's got nothing to do with New South Wales State Health. The way that the department has decided to roll it out is Pfizer comes to GPs, Moderna will go to pharmacy. So pharmacy will have an mRNA. So they will be, starting as of next week, being able to access patients in the pharmacy setting from 12 and up as well as GPs. But please, there's far less doses of Moderna available. So the vast majority of vaccinations still need to really and truly happen with Pfizer in the general practice setting.
So Charlotte, there's a couple of questions here. One, there's a few more coming up about boosters, which I think we can answer fairly easily, in that there's been no advice from ATAGI on boosters yet. The main advice is that if you've had two doses that are less than 14 days apart, so 13 days apart, then you qualify for a replacement dose. It's not a booster, it's a replacement dose. And I think so I don't think boosters are going to be coming for a while because we're still trying to get everybody that first vaccination. The other question that's coming from for Kerry here is around over 60s eligibility for Pfizer and patients attending hubs and getting it over 60, and questions about eligibility.
So look, I'm not aware of the fact that our hubs are open to over 60s for Pfizer. You know, clearly there's always a case example of someone who slips through the crack or the eligibility checker or whatever. Our clear priority is getting people vaccinated. We need to get that first dose and that second dose. And at the moment, many younger people haven't had the opportunity of having a vaccine. It's pleasing to see that we've got reasonable uptake in young people. So I actually don't think we're going to get vaccine hesitancy till very, very high levels. And I'm actually, you know, want to be the most vaccinated state in the world. And so please work with me and help me achieve my dream. I need that, you know, I actually think we can do well over 90%, 95% vaccine coverage. And it is so important. COVID is a pretty horrible disease. And I think we've really got to get that message out that to not be vaccinated when we've got such safe and effective vaccines is really a tragedy.
Yeah, I think there's still a lot of access issues at the moment, and I think that'll play out well. One of the other questions coming up is around vaccination post-infection. And again, that's fairly, do you want to answer that?
So there's a ATAGI advice about that, which indicates that generally we consider people are immune for about 6 months after their original infection. There will be circumstances where people might work in high-risk industries or high-risk settings where there's an earlier vaccination, or particular considerations which might be in rural, remote and other settings. So as a general rule, you're considered vaccinated, you're considered immune for a period after your infection. But again, that advice will change as we've got more access to different vaccines. Keep yourself abreast of the guidance, but there might be circumstances where we do actually vaccinate people before the 6 months time.
And one of the other questions coming up here, which I don't think is really for you, I think it's more an air issue, is around patients that have had J&J or one of the Chinese vaccinations too. So they're fully vaccinated, but they're not yet able to be registered on air.
Look, we're seeing a lot of that, and there's just going to have to be some fixing of that, particularly as we link particular activities to vaccination status and work through that. Clearly, our priority at the moment is just getting the licensed vaccines in Australia into people. But I've heard that from a variety of different sources, and I'll certainly escalate some of those issues as we go forward.
And can I also address, someone's asked why GPs have been giving AZ, are crying out for an mRNA. If you haven't been given access to Pfizer yet, please approach your PHN, because I did quite a bit of campaigning, and I'm well aware that anybody who wants to vaccinate now with Pfizer can actually have Pfizer straight away without any requesting formal documentation. As long as you're participating in the NIP program with the state public health unit, then you now qualify to be able to give Pfizer vaccinations. Obviously, you still need to do all of the training modules, the same as everybody. That doesn't change, but just approach your PHN. There is now plenty of Pfizer for general practitioners, and I really, really want to encourage any GP who hasn't yet started vaccinating to take on Pfizer, so we can really roll out Pfizer to your patients in the safest place for them possible. And and there's a lot more Pfizer, can I tell you, than there is Moderna. There's very little supply of Moderna, but a lot of Pfizer.
And Charlotte, can I just echo that? One of the strengths of the New South Wales system is the GP backbone. It allows us to achieve a very high rate of vaccination coverage in children. And we're going to want to make sure that we've got very significant coverage of our 12 to 15s, our over 16-year-olds. And then as boosters come in, GPs will play a pivotal role in delivering those boosters alongside what you do with your annual flu vaccine. And then if there was childhood vaccination, again, GPs, I would see, not that that's been approved. Clearly, we're waiting for the, ATAGI is waiting to review all of the data on that. But again, having GPs enabled to give the Pfizer vaccine is really critical to our ability to rapidly scale. And GPs have just done a magnificent job in that scaling. And wouldn't it be good to even do more?
Yep, thanks, Kerry. And can I also note that someone's asked about Hep C and B patients. They safely can be vaccinated with any of the vaccines. There's no preference. It will depend upon their age. But if they are 60 and over, they can safely have AstraZeneca. And under 60, then obviously the preference is Pfizer.
And there's been a few questions here around vaccination exemptions, and they will start to become an issue. But I think when I've been working at one of the hubs, and we've seen a lot of 12 to 15-year-olds coming in, and there is a lot of anxiety there around having the COVID vax. But I don't think that they will be part of the vaccination exemption. I think there's going to be very strict criteria. I don't know if you want to, I know ATAGI is working on a document for that. I don't know if you want to comment, Kerry, on that.
Yeah, look, I think vaccine, I won't talk about the specific issues of 12 to 15-year-olds, but I just think not wanting to have an injection or is not going to be sufficient to do that. to justify it being a medical exemption. I think we have to really work hard at supporting our patients to become vaccinated, and I'm doing that for their own benefit. It is really important that, you know, you must deal with this every day, and it may be that a patient that has some anxiety is best dealt with by the general practitioner, not in a mass vaccination setting. So I think it's really about being very flexible and understanding certain patient groups might need a particular supportive environment. Not that our vaccination hubs are not, but just a GP that they've had that relationship for many years to support them to get vaccinated.
Thanks, Kerry. Look, there's still quite a lot of vaccination questions. Just to say, in terms of Bell's palsy risk, no increased risk with the mRNA data that I've seen. There is a slight increase in Guillain-Barré with AstraZeneca over Pfizer, but you know, there's Guillain-Barré is a risk with a number of vaccinations, and it hasn't come out as a specific concern. Do you want to add anything to that, Kerry? Or
no, look, I think the key message is, given the risk of COVID, and we know that that disease will have such inherent risks, that the risks and benefits are clearly very positive in the favour of vaccination.
So what I'm hoping we can move into at this point is just a quick conversation about the management of COVID in the community, given that we do now obviously have a significant number of people who have got COVID, who are, you know, it's more and more likely that GPs will be being asked to assist with care in one way or another. So Kerry, do you mind running us through what is the sort of the current overall model for New South Wales Health, and what is the role of GPs?
And look, I think to put it on the table, the role of GPs is a really important one, but I know that there's some processes being developed, and I know, Charlotte, you're engaged in those, to look at how we can more consolidate the role of general practice in the care pathways. Obviously, with the rapidly rising numbers, there had to be a lot of models of care developed to make sure that we've got visibility and clinical care provided in a risk-assessed basis. So a number of the local health districts have developed partnerships with various groups to actually provide digital support to low-risk cohorts, and that's allowed them to focus on higher risk cohorts. And obviously there's the clinical practice domain has developed a model of care. I want to say that that's been developed by necessity given the resurgence in cases, but I want to express that New South Wales Health wants to work with general practice to look at how we can better incorporate general practice into those models of care going forward. And I know that we're having planned a webinar to talk about some of the clinical management issues with COVID as part of just one component of that discussion with general practice.
Thanks, Kerry. So I just sort of want to add on that. I think that there's been a number of GPs who have been asked to assist with some with management of COVID positive patients in their footprint, and have been quite reluctant because they felt nervous about it. So we are doing a number of things in partnership with New South Wales Health. As Kerry mentioned, there is a whole lot of development about shared health pathways, and the Health Pathways team is doing an amazing job at actually developing really very clear guidelines about what are the red flags, what needs to happen, etc. In the meantime, with the Agency for Clinical Innovations, we are looking at what models of care might be possible in partnership with each of the LHDs. And so starting next Monday, we're going to run a series of webinars actually really telling you exactly what is happening, what are the models of care, how can general practice assist with that. So next Monday at this same time, we will be running a an actual webinar to start that conversation. Very keen for everybody here tonight to actually be able to provide their time again to listen in and provide us with the sorts of questions that we need, so we know what sort of upskilling everybody would like in terms of increasing their confidence to be able to provide general practice care to patients who are COVID positive. Kerry, Penny, do you want to add anything to that?
I think just one of the things that's coming up a little bit here is that GPs are very keen to have a system where they're notified as soon as their patient results are positive, so that then they're aware of what's going on.
Yeah, well, we're very keen for that as well. And also just to be kept in touch with what is happening. So even if the GP isn't involved in the care, that they know what's happening. It's like any shared care arrangement. The more information you're given, the better you get at actually providing the sharing care. And, you know, I know from Kerry's perspective, that it's really going to help the whole health system. The more care GPs can provide in terms of that sort of shared care arrangement going forwards. And that's the goal, particularly if we're having COVID normal as the ongoing arrangement. Any other questions at that point, Penny?
There's a lot coming through. So there's lots of questions coming through about the vaccine at the moment, but there's one here about do patients discharged from hospital post-COVID need to isolate or have a negative COVID test before coming to see a GP for review? So what's the system when a COVID positive patient is discharged from hospital?
So there's I'll answer that question in two different ways. There's a clearance that patients are given. So that's when they're, for instance, 14 days if they're symptom free. So that's the cDNA criterion is used for discharge, and patients should be provided with that. We're actually not recommending that patients get a clearance swab, because we know with the sensitive tests they'll find it and they're non-infectious, but they'll still detect the virus. So that's a problem for them. And it's something that the GPs will have to be aware of as well. And then obviously if people are discharged from hospital, they may be discharged at any point in their course. So they may still have symptoms and therefore not be cleared. So it is important that there is to check the infectious status of the patient, but they should be aware of it, and also the clinical teams.
Thanks. And I think in terms of the models of care and the red flags, etc., that's all very much going to be part of the health pathways, and any collaborative sort of formal shared care arrangement going forward will obviously have to deal with the funding and who sort of actually providing the patients with the remote monitoring equipment, etc. But look, it's still very early on in the conversation. Penny?
Yeah, look, so one of the things we were talking about that I was actually keen that we chatted about on the webinar was around the fact that the Delta virus is fairly infectious, and that if you get 4 people in a household positive and you've got another person there, they will possibly be positive. And then the issues around actually testing them with a swab and how to manage that in general practice. Kerry, did you want to talk about that?
Look, I think we, with the testing levels that are being done, a lot of the private pathology are not doing home collections anymore. So that's a challenge. And I think as we build COVID normal, it'll be important to factor in whether we can re-establish some of those services that developed. Even before we were just chatting that, you really do need to think that that person is positive. So if there's a deterioration, if they've got cough, they've got COVID. It is that infectious that if by the time someone in a household is getting picked up, that will be at least 24 hours. The person's been infectious for at least a couple of days before that. They will have already infected the people in the household. So I think having that high index of suspicion if there's any household members or someone is a close contact, in terms of guiding what might be the response of the GP if they get a call from any of those close contacts, they do need to think of them as, a probable COVID case. And then I think we do need to work through the methods of testing. Obviously, they can go to a drive-through testing clinic if they've got a car, but obviously they're constrained in terms of their ability in other settings, unless they're very safe walking distance from a COVID clinic and won't be coming across anyone while they're doing that.
And then a couple of questions here about people being post-COVID post-COVID-19 disease being asked to get a vaccine as soon as possible. Is that the case or not necessarily? No.
No,
Okay.
that goes back to my previous statement
Yeah,
that they wouldn't
yeah.
be asked to get a vaccine post-COVID. Yeah.
And then the other question coming up is, so if they're remaining positive post-COVID, how long does that last for? Do we know how long that goes for?
I think we've had some examples where you can detect the virus for a long time into the future. And also if they have any intercurrent illnesses, like rhinovirus or anything, we find that they excrete it. So it's really going to be important into the future, discriminating what's occurred for them. So it's complicated, and we experienced that with the previous strains as well, that people can be positive and often can have the virus excreted when they've got the presence of other viruses as well. The fragments get released. So I think it's just a factor we're going to have to take into account with so many people having been infected, but they're unlikely to get reinfection with Delta within that 6-month period.
And I think that's possibly going to be one of the medical exemptions that comes out, having had COVID in that first 6 months, but wait and see. Look, Beth, I think we're just about out of time. So did you want to close?
I do, but before I might do that, I might pass you over to Charlotte quickly just to talk about the faculty member meeting, if that's okay, Charlotte.
Yep. So we've got a couple of things. So this Wednesday, we have the New South Wales ACT faculty member meeting, and we've got a guest speaker, Professor Kay Wilhelm, who's actually going to talk to us about looking after ourselves. And I think we're all feeling burnt out over it, and really just, you know, we're all, well and truly had enough. And so Kay's got some great tips. It's always been her passion about looking after doctors and keeping them well. So I really recommend that as being a good session to attend. Please do. And then the final thing was, again, that reminding you that next Monday we'll be starting this series on community-based care for COVID-19 infections. So this is your opportunity to hear about what it is that the models of care are currently doing, and have us be able to interrogate it and feel confident as a GP to actually be part of your own patient's care in the framework that you feel okay about doing, not being imposed upon you in any way at this point in time. So those are two opportunities. And then a final reminder, please, if you aren't currently being vaccinated, you can put your hand up to get it. There is Pfizer vaccine out there waiting for you. So please contact your PHN, and please also remember the vulnerable populations such as Aboriginal and Torres Strait Islanders, who we really do need to encourage and facilitate to being vaccinated so that they're safe if and when they are exposed to COVID into the future. Thank you, Kerry. Thank you, Kathy, and Penny and Beth for this evening, for covering a vast amount of obviously important information for all of us in GP land.
Perfect, thank you. And I've popped both of those registration links in the chat box as well if you wanted to register for those. But yeah, thank you very much, Kathy, Kerry, Charlotte and Penny. Always very great, these sessions, and look forward to speaking with you all next month. Thanks, have a great night.
Cheers.